So today we're going to talk about implantable cardioverter defibrillators. My name is Usha Tedrow, and I'm the director of the Clinical Cardiac Electrophysiology Program here at Brigham and Women's Hospital. Here are my disclosures. So sudden cardiac arrest or sudden cardiac death is an important public health problem in the United States. There are over 400,000 out-of-hospital cardiac arrests per year, and about half of these are in patients having a myocardial infarction. Many of these patients, it's the first manifestation of their coronary artery disease. Still, even in the most modern resuscitation programs, there's a 95% out-of-hospital mortality from sudden cardiac arrest. Our goals for treatment are prevention and recognition of high-risk populations. So how does a cardiac arrest happen in a patient with coronary artery disease? In many situations, a patient has stable coronary artery disease and an old myocardial infarction, and they develop monomorphic ventricular tachycardia. This is a gross pathology specimen of a heart. This is the endocardial surface, and this is the epicardial surface. And you can see here that the myocardium is thinned and fibrotic in an area of a transmural myocardial infarction. However, at the border zone of the scar, there are areas where there are surviving myocytes woven in with the scar tissue, and this produces poor cell-cell coupling and slow conduction between the myocytes that are substrate for reentry. Patients can then develop monomorphic ventricular tachycardia using the old scar tissue, which then in turn stresses and fixed coronary artery disease that the patient may have, and they can degenerate later to ventricular fibrillation after a long period of monomorphic VT. So as I mentioned at the beginning, the survival after a cardiac arrest out of the hospital is about 5%, and even in the best ambulance and EMS programs. And the reasons for that are several. Many of the events occur in the early morning hours and are not witnessed by anyone. If a patient lives alone and they have a cardiac arrest at 6 o'clock in the morning or 5 o'clock in the morning, there may be no one to call for an ambulance or a defibrillator. There can be difficulty reaching victims within 6 to 8 minutes for defibrillation, and as we all know from ACLS, early availability of defibrillation is very important to survival. So how can we prevent morbidity and mortality from sudden cardiac death? First of all, primary prevention of coronary artery disease is extremely important. Preventing those myocardial infarctions in the first place, diagnosing old myocardial infarction or even preventing them can be an important preventative measure. Early identification of structural heart disease, either by physical examination, EKG in the office. Identification and avoidance of medications that increase risk, such as QT prolonging medications. Use of community resuscitation programs, CPR, and emergency response systems. Community-based automated defibrillators, such as AEDs in the community, have been very effective in terms of improving survival rates from sudden cardiac arrest. And then for our patients where our pretest probability of having a cardiac arrest is very high, use of implantable cardioverter defibrillators is very important. Here's a chest x-ray of a patient with an implanted defibrillator. You can see the defibrillator here in the left pectoral region with two wires that go into the cephalic vein, then the axillary vein, and then the subclavian vein here. Sometimes the defibrillator wire may have a coil at the SVC-RA junction, or it may not have this coil at all. Then there's also a coil in the right ventricular apex, and that participates in the shocking circuit. So if there is an SVC coil, it is typically tied to the outside housing of the can, and that's one pole for defibrillation, and the other pole for defibrillation is the right ventricular coil that can produce the shocking vector that can defibrillate the heart. So how does the device know what to shock? So down at the apex, there's a bipolar electrode pair in many types of defibrillator configurations. Sometimes this is an integrated bipolar pair, and sometimes it's a true bipolar pair. But either way, every time there's a heartbeat, so looking here, this is a rhythm strip with a cartoon of an ECG and a cartoon of a patient going into ventricular fibrillation. This is a simulation. And this is an idea of what the electrical activity would look like if you hooked up a pair of alligator clips to the end of this wire. What would it look like? So down here in the right ventricular apex, at some point during the QRS complex, the wave of depolarization is going to go past your electrode and make a little spike on the electrogram. Here again, during another sinus beat, you see another spike. Here, the patient goes into ventricular fibrillation, and you see that even though the ventricular fibrillation is sort of sinusoidal on the surface ECG, every time the wavefront passes this electrogram, it inscribes a bit of a spike on the surface ECG. Sometimes this looks a bit more shaggy than what appears here, but this gives you an idea of what the defibrillator sees. Then we program a sensitivity, which is a bar above which it counts the beats. So if the signal goes above the sensitivity bar, the device on the marker channel tells us that it thinks it sees a heartbeat. So it says VS here to tell us that it's seen a heartbeat. Here's another marker that shows that it saw a heartbeat. And you can see here when the fibrillation starts that the marker goes much faster. And we basically tell the device that if you see too many of these sensed events within too short a period of time, you should charge up and shock the patient. There are actually two ways that the device can get the patient out of their arrhythmia. It can either charge up the capacitors and shock the patient, which can potentially be painful if the patient is still awake, or it can deliver paced impulses that are just a little bit faster than the sensed arrhythmia, called anti-tachycardia pacing, and that can get the patient out of their arrhythmia as well. So here's a real-life version of an interrogation from a patient that went into ventricular fibrillation. And a lot of times, the device may not record electrograms from the events that happened before the sensed event, but it can show you the marker channel. So here it shows you that the patient was in some kind of slow ventricular rhythm with a RR interval that's about 1,000 milliseconds, so approximately a heart rate of 60. And then all of a sudden, it goes very fast, very fast, very fast. And right here, the device gives you a notation that this has gone on long enough. We need to charge up the capacitors. And during this time, it's all charging. And then a shock is delivered here. And you can see the patient is back in a normal rhythm. So this is an example of a life-saving shock that was delivered by the defibrillator to save the patient's life. So the Achilles heel of this system is really the wire that connects the can to the heart. That wire can sense noise from outside electrical sources, something called electromagnetic interference. It can also break if the patient is very active, or if the lead is old, or if it's defective in some way. So here's an example of a patient that has noise from their lead. So when we look at this surface ECG here, we can see with our mind's eye that there are beats here, but there's a lot of shaggy electrical signal superimposed on the beats that is electrical noise. This is a patient that was having electrocautery-induced noise, and here you have very rapid sensing in the marker channel that does not reflect these slow beats that are the true heartbeat that the patient is having. And here you can see that the patient actually did charge up the capacitors and deliver a shock to the patient in sinus rhythm. Now, this is very painful for the patient if it does happen. It's also dangerous because it could initiate an arrhythmia in a situation where there was not an arrhythmia to begin with. And in a situation where the lead is fractured, it could initiate an arrhythmia that the device is incapable of resolving on its own. A lot of the defibrillator systems now have early warning systems for defibrillator wire fracture. So you notice here on this slide that I show you that it is noticed that there are very, very short VV intervals that have been sensed at 120 or 130 milliseconds. These are very, very short intervals that are very likely to be electrical noise rather than a biological event from inside the heart. And it's important to recognize that these are likely due to a defibrillator wire failure rather than a true arrhythmia. Here's another example of an electrogram, and the question here is this shock that was delivered at the end of the strip for the right thing? So I showed you before an electrogram from the ventricle, from the right ventricular apical wire. So here you see in the ventricle, there's beating that's rapid, but not as rapid as ventricular fibrillation. It's also irregularly irregular in the ventricle. And here's the tracing from the atrium. And you notice that the atrial wire is seeing very rapid, irregular beating. So this is a patient with atrial fibrillation with rapid ventricular response that's inappropriately detected by the defibrillator, and a shock is delivered. That's an inappropriate therapy. So what is the data to support using implantable cardioverter defibrillators for prevention of sudden death? Since the mid-90s, there have been a number of randomized trials to support the use of implantable cardioverter defibrillators. Earlier in the literature, there was more support for potentially using antiarrhythmic drugs, but it's become increasingly clear that antiarrhythmic drugs are an imperfect solution to the problem of sudden cardiac death, especially in patients with structural heart disease, and that the implantable cardioverter defibrillator is the most reliable method of preventing sudden death. So one of the landmark trials is the only secondary prevention trial that exists. This is the AVID trial, published in 1997 in the New England Journal of Medicine. This was 1,000 patients that were randomized to implantable cardioverter defibrillator versus antiarrhythmic drug therapy, patients who had presented with ventricular fibrillation, ventricular tachycardia with syncope, or sustained VT with an ejection fraction less than 40% and symptoms near syncope, heart failure, or angina. And there was no reversible cause identified. Those who are thought to have a reversible cause, whether electrolyte cause or reversible ischemia, were kept in a registry. The antiarrhythmic drug that was used was mainly amiodarone, and the trial was discontinued at 3 years due to survival benefit associated with the implantable cardioverter defibrillator. There was low use of beta blocker in the antiarrhythmic drug group, which is the main criticism of this trial, but is an old trial and it is unlikely to be repeated due to the strong result in the ICD group. The first MADE-IT trial was also published in the late 90s, also in the New England Journal of Medicine, and this was about 200 patients that were randomized to ICD versus medical therapy. They had prior MI, left ventricular ejection fraction less than 35%, and asymptomatic non-sustained VT. They all went to an EP study and were found to have inducible, non-suppressible VT at EP study. This trial was also terminated early because the ICD was associated with a survival benefit. There was, again, low use of beta blocker in the antiarrhythmic drug group, and that's partly because in the 90s it wasn't felt to be as safe to use beta blockers in patients with LV dysfunction. The other possibility is that the presence of the ICD permitted the use of beta blocker because of the pacing backup that the ICD provided. The MUST trial was also a seminal trial that was published at the end of the 90s in the New England Journal of Medicine. There were 700 patients that were randomized to electrophysiology study guided versus non-electrophysiology study guided therapy. The interesting thing is that the ICD was not really part of the study design of this trial. These are patients with coronary artery disease, ejection fraction less than 40%, and asymptomatic non-sustained VT. They had inducible VT at EP study, and if they were non-suppressible, they were eligible for an ICD. These were largely surgical ICDs that were implanted, though some transvenous ICDs were starting to be used. The ICD was associated with reduced mortality with respect to both EP study and non-EP study guided medical therapy in a retrospective analysis. And the Cabbage Patch trial, which was 900 patients, left ventricular ejection fraction less than 36%, pre-revascularization, so these were all patients going for coronary artery bypass grafting. They had an abnormal signal averaged ECG as their entry criterion for the study, and they had an epicardial surgical ICD placed at surgery. This was the main trial result, which showed no mortality benefit in the ICD group at 3 years of follow-up. And some of the reasons for this were that the thought was that revascularization was actually a powerful antiarrhythmic for some of the patients. In addition, there were some complications of the epicardial surgical ICD, which is quite a morbid procedure that reduced the benefit of the ICD in this trial. The MADE-IT2 trial was published in 2002 and was 1,200 patients. Patients were randomized 3-2 to ICD versus conventional medical therapy. The patients were greater than 30 days out from a myocardial infarction prior to implantation and had an ejection fraction less than 30%. The primary endpoint was all-cause mortality, and there were secondary endpoints of cardiac mortality and arrhythmic death. At 20 months, the ICD was associated with a significantly reduced mortality compared to conventional therapy. The last major ICD trial that I'm going to talk about today is the SCUD-HEFT trial. The inclusion criteria for the SCUD-HEFT trial, which was published in 2005, also in the New England Journal of Medicine, was symptomatic congestive heart failure. So in contrast to the MADE-IT2 trial, which was just low ejection fraction, these patients actually had to have NYHA class 2 or 3 heart failure due to ischemic or non-ischemic dilated cardiomyopathy. The ejection fraction was less than 35%. Patients had to be greater than age 18 with no upper age limitation, congestive heart failure of duration greater than 3 months, and they had to be on optimal medical therapy for more than 3 months on appropriate dose of ACE inhibitor and a beta blocker if tolerated. It was a randomized trial, double-blind, placebo-controlled, 2,500 patients, 800 placebo, 845 in an amiodarone arm, and 829 in an ICD arm that were all single-chamber devices. All patients were on optimal medical therapy, and they had 45 months mean follow-up. So here are the results of the SCUD-HEFT trial. The main result from this trial was that the amiodarone and placebo groups had a similar mortality rate. So this really put to bed the idea that amiodarone by itself could improve mortality from sudden cardiac death in patients with structural heart disease. However, there was a survival benefit to having the implantable cardioverter defibrillator. Let's talk a little bit about the ICD guidelines. These are the Class 1 ICD guidelines. Left ventricular ejection fraction less than 35% due to prior MI and at least 40 days post-MI with NYHA functional class 2 or 3 heart failure, so the SCUD-HEFT trial that we just talked about. The second one is LV dysfunction due to prior MI at least 40 days post-MI with LVEF less than 30% and functional class 1, and this adds in the MADE-IT2 groups. Survivors of cardiac arrest due to ventricular fibrillation or hemodynamic unstable sustained VT after evaluation to define the cause of the event excludes reversible causes. This is the AVID group. Non-ischemic dilated cardiomyopathy with an EF less than 35% and class 2 or 3 heart failure, also the SCUD-HEFT group. Non-sustained VT due to prior MI, EF less than 40 with inducible VF or VT at EP study, the MUST group. Structural heart disease and spontaneous sustained VT, whether hemodynamically stable or unstable. Syncope of undetermined origin with clinically relevant, hemodynamically significant sustained VT or VF induced at EP study. Some of the rarer birds that are indication for ICDs are in the 2A group, which is long QT syndrome with syncope or ventricular arrhythmia on beta blocker, unexplained syncope with significant LV dysfunction and non-ischemic dilated cardiomyopathy, sustained VT with normal or near normal ventricular function, catecholaminergic polymorphic VT with syncope or sustained VT while receiving beta blockers, prevention of sudden death in patients with hypertrophic cardiomyopathy, Brugada syndrome, ARVC, who have one or more risk factors for sudden death, cardiac sarcoidosis, giant cell myocarditis, or Chagas disease, and non-hospitalized patients awaiting transplantation. Let's talk about a couple of cases. Here's a 55-year-old man with a primary prevention ICD implant with ischemic cardiomyopathy. He's been stable for 3 years and now presents to the emergency department after 5 successive shocks from the device at home. Here are the intracardiac electrograms from the defibrillator. What should we do next? Should we start lidocaine? Should we start amiodarone? Should we perform cardiac catheterization to rule out reversible cause of ventricular arrhythmia? Or should we place a medical magnet over the device? Let's look at the tracing again. The top is the atrium, the bottom is the ventricle. Atrium, ventricle, atrium, ventricle, atrium, ventricle. The atrium looks a little bit different here compared to here because there's pacing here, and this is a sensed atrial arrhythmia. What do we notice, though, on the marker channel? There are many more ventricular sensed events than there are true ventricular events on the ventricular electrogram. The shock here is delivered with the patient essentially in sinus rhythm. So this is a malfunctioning device that's showing you a lot of marker channel abnormalities rather than showing you any true arrhythmia. So what is the correct answer? We want to put a medical magnet over the device. A magnet will turn off the therapies for the defibrillator so that we can figure out why the device is shocking the patient for something that is not a real arrhythmia. Question number 2. Which of the following is the best candidate for ICD therapy? A 57-year-old woman with syncope and non-ischemic cardiomyopathy, a 45-year-old man status post-LAD stent following anterior MI complicated by ventricular fibrillation in the field, a 33-year-old man with recurrent leukemia, ventricular arrhythmias, and syncope, an 87-year-old man 2 weeks after multivessel percutaneous intervention with ejection fraction of 25%. So the one of these that best fits the ICD guidelines is the 57-year-old woman with syncope and non-ischemic cardiomyopathy. She has a clear indication for an ICD. The 45-year-old man is too close to his myocardial infarction to have his ejection fraction assessed for primary prevention, and the ventricular fibrillation during the event of his anterior MI is actually not a risk factor for sudden death. The 33-year-old man with recurrent leukemia, ventricular arrhythmias, and syncope is a tricky candidate for an ICD therapy because he has limited life expectancy. A patient is expected to have life expectancy of at least 6 months to a year to qualify for implantable cardioverter defibrillator therapy. The 87-year-old man, 2 weeks after multivessel percutaneous intervention, is also too close to his revascularization to qualify for primary prevention ICD. Here's another question. A 55-year-old man with a primary prevention ICD implant for ischemic cardiomyopathy. He has been stable for 3 years now and presents to the ED after 1 shock from the device at home. Here are the electrograms of the event. What should we do next? Should we start amiodarone? Should we start anticoagulation? Should we perform a chest X-ray? Or should we put a medical magnet over the device? So here you see there's again an atrial electrogram on the top and a ventricular electrogram on the bottom. You see that the ventricular rate is much faster than the atrial rate. That's true all throughout the tracing. So this is sustained monomorphic ventricular tachycardia. There's a shock delivered here that tried to get him out of VT. So it would make the most sense to try to start amiodarone to control the ventricular tachycardia. Starting anticoagulation does not have any import on the recurrent ventricular tachycardia. A chest X-ray is also not going to help decide what our next therapy should be. And you do not want to put a medical magnet over the device in a patient having true ventricular arrhythmias because the implantable cardioverter defibrillator can help you to treat the patient as they have recurrent episodes.